All right. So we'll get started. The rest can catch up here. All right. Hi, Lisa.
Oh. Hi.
How are you?
Good. You?
Good. All right.
I'm having trouble hearing very well. I'm not sure what I'm doing wrong.
Is the volume on your computer turned all the way up? That would be my guess.
Hey, yep. Dr. Brady, it's showing that on my screen it says guests are waiting to view. So I don't know if there's people like in a lobby or whatnot. I don't know why I see that.
Probably because you might need to close it, but everyone's been checked in that's in the lobby that I can see.
Oh, okay.
All right. But thank you. All right, we'll just get started. Before I begin, does anybody have questions? Nothing? All right, I'm going to open the chat on the side so I can also see the chat as we go through this. So you can unmute and ask a question, or you can write something in the chat. I'll watch both. Do you only see the case on the screen, or do you see more than the case?
Just the case.
Okay, good. Then you won't have to see all my side stuff that I'm including. Okay, so we're going to begin with a 16-year-old female that comes to see you in your office, and she wants birth control. She's never been on birth control before. She currently has regular periods. They're painful, and she would like them to go away. What are some options to consider for this information? So what I want you to do is take a minute and write down or make note of the key phrases or key things that you need to pay attention to in this scenario. And you can unmute or you can put them in the chat.
Well, she's never been on birth control before.
Yep, so that's important. Mm-hmm.
Pain part, that her periods are painful.
Mm-hmm. And what else about her periods is an important consideration?
That they're regular.
Yep. And then what about the patient's desire?
Well, she wants them to go away, and she needs to be educated that that's not how that works.
True, but if she wants them to go away, there's options that we have to make her not have a period for a long time. So when I look at this, I think about, okay, she wants them to go away. Yeah, it's not going to take it away completely, but we can certainly, if she doesn't want to have a period, provide her with an option that is likely to make them much less frequent or amenorrheic. Does that make sense?
It does.
Okay, good. And then what questions would you want? Okay, let me back up. I'm kind of punting here. So why are painful periods important to note?
It could be a symptom
of, oh, I'm sorry.
No, that's fine.
Sorry, no, I think we're going to say the same thing, like a different condition.
Could be a different condition, but 16-year-olds very commonly have painful periods. And this is one of the big things that you'll see somebody with. And so you want to provide them with an option that is used to treat dysmenorrhea. Does that make sense?
Yes.
Okay. But yes, you need to consider, Liz, you're right, other reasons that she might be having painful periods. And so that's where a good history would come in. Okay, and what's to know, or why is it important to know if her periods are regular or irregular? It's important because if she's not ovulating or not having regular periods and she desires to have regular periods, that would help us to decide what birth control as well. So in this case, she wants them to go away, but let's say somebody is 16, she's coming to see you, she's having real irregular periods and she wants them to be more predictable. Your birth control options would be different then. Does that make sense? Yes.
Yes, it does.
All right, perfect.
You're getting a baseline of what her regular period is without any medication.
Yeah, and plus also, it might help you with determining pregnancy or if that's a risk factor consideration. And also, if you have to counsel her on like when to start birth control or decide when you want to start it, that information is helpful. So you get a lot of information in just a couple of sentences. And I think oftentimes we overlook some of those vital cues or clues that help us in our decision making. Okay, so those are 4 good clues. You picked up on all of them. What additional history do you want?
Well, I think it's important to ask like sexual history, like if she's currently sexually active.
Yep. What else?
I was going to say too, since she's 16, and this would obviously, you'd have to clarify that she's not going to want to become pregnant soon. And you could go for a birth control that lasts longer, maybe like an implantable method versus something that needs to be taken every day.
Yes, 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 yes. What else?
Any clotting disorders, any family history of clotting disorders? Or
Yep, very good. What else? There's probably a half a dozen other things to think about.
Ask her if
So
she's
reviewing,
No, you go ahead, Jen.
I was gonna say do a medication review if she's on any medications, but that might trigger you to ask, if she has anything else going on, health-wise.
Yep, so a medication review, because remember, some of the birth control options can interfere with other medications, and that will help you decide if you need to do something different in terms of dosing or the type of method. Good. What else? What's a big one that's related to clotting?
does she smoke?
Yes, very good. And I ask all the way down to age 10. Now, granted, most 10-year-olds aren't coming in for birth control. I think the youngest I've had is 13. However, I've had a pregnant 12-year-old and I've had kids that smoke as young as 8 years old. So you really can't assume that just because they're a young person, they're not smoking. And that will increase their risk of blood clots. Good. All right. Can anybody else think of anything else that they want to consider?
Is she going to be realistically able to take a pill every day and remember and do it at the same time?
Yes.
She's only 16.
You're right. And you have very mature 16-year-olds and you have very immature 16-year-olds. That's an age that's very difficult because of that. And it just really, it depends on a lot of factors. So yeah, you need to make sure she understands that. Now, the beautiful thing is most 16-year-olds have cell phones now, and there's apps that help them to remember to take their pill and set the alarm. So, but that's very important, is her ability to adhere to treatment. What are some other things that affect adherence?
I don't know if this is wholly appropriate or not, but something that comes to my mind is I wonder if her parents are supportive of her decision, or if they're not, and if she would have any, she would have to hide the medication or.
Yes, that's a very good consideration in a 16-year-old because she can seek birth control without parental consent. So if it's something that she's got to take every day and get a prescription for, is she likely going to be able to do that month to month and day to day? Good. You guys brought up some really good things. So when I look at, I don't know what slide it is because mine aren't numbered, where the slide in the birth control presentation where it says where to begin, take a thorough history or a review of your patient's history. So that means you want to get her blood pressure as well, because if she's got an elevated blood pressure to start with, that's a concern. But in terms of history, you want to get a menstrual history and a sexual history, and you noted that. Family history to include blood clots, but I would also assess MI, heart attack or stroke, and at what age, and if they knew the reason why, and family history of female cancers. Remember, you can put somebody on an estrogen hormone and they have a family history of estrogen positive breast cancer. So a good family history in those key areas is important. And then a medication review in case there's interactions, and then habits, the smoking. So we got all of those. The risk factors and contraindications. So what are some absolute contraindications? Do you remember that slide? Anybody?
History of DVT or PE.
Yep. What else?
A known or suspected pregnancy.
Yep. What else would be applicable here?
History of breast cancer or like suspicion.
Mm-hmm. Yep. And undiagnosed abnormal bleeding. In a 16-year-old, this would be very unusual, but it still has to be in your thought process. So those things in your history that you should be asking are those related to those specific absolute contraindications. And then same with the relative contraindications. Do they have those other things that are listed on that slide themselves, like elevated blood pressure, a heart defect or murmur, diabetes, seizures, migraines, etc. Make sense? I hope so. I hate not seeing your faces. You know, you can put your faces on.
Yes, it does.
All right. So,
I don't think you want to see my face when I'm in the car.
all right. So going down that slide, where to begin? We talked about medications and her fertility goals. So she wants her periods to go away. We're assuming that at 16, she's not wanting to get pregnant, but we don't know that for sure. And Liz alluded to that. We need to know what her pregnancy desires are, because someone at this age ideally would be on a long-acting reversible contraceptive like the implant or an IUD. What is another condition? Is there any other conditions you might want to ask her about when deciding what birth control you want to prescribe? What else would be common in a 16-year-old? What are 16-year-olds worried about?
Acne?
Acne, yep. Acne and weight gain. They want to know, can this help my acne and will it make me fat? All the time. I mean, that's true of most females, but especially in the adolescent population. So you have to be very cognizant of those concerns, that body image concern. All right. So with all of this information and all the things we talked about, what are some options for this patient? Go out on a limb, guys. This is where you learn.
Well, you mentioned the implant, so like Nexplanon.
Mm-hmm.
I mean, just the daily.
I think the
oral-
Mirena is a really good option. Oh, sorry, Emily, go ahead.
No, I mean just a oral contraception if she could take it every day.
Yep. So I have IUD, Nexplanon, oral contraception, because the Mirena is an IUD. There's another one that's common in this age group, and probably one of the more common ones. Any guesses?
I don't know.
The
but-
Depo?
Depo, yeah,
Yeah.
Depo-Provera. So let's talk about each of those options, the pros and cons for this patient. So let's start with the oral contraceptive. What would be the pros to having that?
It would help with the pain. The
It could
dysmenorrhea
help
that
with
she's
the
having.
pain. Yep. Could we make her period go away?
Not with oral contraceptive.
Actually,
thought-
we,
You
I said
could
you
if
can
you
just-
Can?
take them back to back. Oh, I'm sorry.
yep, no, you're right. I know where you're going with this. We actually can now. You can skip that inert week and just do 3 weeks back to back of the active pills of 3 pill packs, and then let somebody have a period. So that is an option now. Seasonal is a good one for that. And I know your book mentions some other options. So that is possible on short term to do that. That's why I made that specific point. What's another benefit of contraception, oral contraception?
If you're not tolerating it for any reason, you can stop, and you don't need to remove it or go through something like that.
Absolutely. It's very easy and plus if they're not tolerating it, there's so many different options. You can try adjusting the hormone doses and see if that helps. Absolutely. Okay. So those are, and they're relatively inexpensive if you can get them, depending on your age and the relationship with your family. So what are some cons to oral contraception?
The
Well, like Emily
ability
said,
to
if the
miss
patient-
doses and it not being can not be very effective if not taken correctly.
If not taken correctly, yeah. Depending on which birth control and the level of hormone, you may only have a 3-hour window, and you can get pregnant. So that's definitely a downfall, and having to remember to take a pill every day. So adherence is the biggest thing with that one. Good. Okay. So what is, and I'm someone that got pregnant on oral contraception when I was married. I was on antibiotics and steroids because I was sick, didn't know any better or didn't think about it because I just felt like crap. And then lo and behold, I got my fourth baby in graduate school. So I think also that we forget about is because so many people take contraception that we aren't very good of educating people. And if we are they able to remember that? So would a 16-year-old remember some of those things? So depending on their maturity, absolutely. I've had girls that come in, they have their period diaries, they have their app all ready to go. They have their condoms in their purse because there's no way they're having a baby or getting an STD, and they are on it. And then I have other people that age that don't even know where their locker is, let alone should they be having sex, but they're doing it, and you're scared for them. So it's the whole gamut when you're dealing with adolescents. All right, next Blanon, or the implant. What would be some pros for the implant?
Well, it's not a daily concern.
It's not a daily concern. Yep, it's longer acting. What else?
It avoids the periods like she wants.
It can. You can lose your period with those. Yep. What else? The biggest thing is it's good for 3 years. So I think that's great. The downfalls, did you remember reading anything in your book about the downfall? And this is the number 1 reason why girls want it taken out. Well, there's 2 reasons that I've had a lot of experience with.
Like breakthrough periods?
Yeah, bleeding
Breakthrough.
irregularities.
Yep, breakthrough periods, and some girls get heavier bleeding with it. And so that's the downfall with it. And also, some girls don't like the feel of it in their arms. So that can be troublesome. And my other experience with using the implants, because they're not cheap to put in, girls are fickle. Teenage girls are fickle. And it's a bigger procedure to take it out, and it's expensive option if in 3 months they don't want it anymore, or they don't decide they've changed their mind. So that's where understanding your patients and knowing your patients well is helpful. There are some practices that will even have them sign a contract that says they're not going to have this removed for so many months unless there's a complication, because girls will have it taken out and then they'll want it back in, and they just can't make up their mind. Does that make sense? I hope. All right, IUD. So the Mirena was suggested. That's a good option. Pros and cons, anybody?
I mean, another pro is you
Well,
kind
the
of forget
Mirena
about it for
eliminates.
years.
Yeah, you don't have to worry about it because it's good for 5 years, 5 to 6 years. So once it's in, it could most likely take her period away. She might have some very light spotting, but she may not have a period for a long time. All right, what else? I'll tell you, it's a more expensive option, but when you have to add up the birth control pills, over a 5-year period, then it becomes much more reasonable. It's also a procedure, so there's risks involved, very minimal risk, but there's still risks involved. But the other good thing is it's reversible, and so you can take it out, and very quickly you can be able to get pregnant if you so choose. Now, the last option we didn't talk too much about, and I think is probably where I would go with this patient, without knowing more history than what's there, is the Depo-Provera. Why would I think that Depo-Provera, the injection, would be a good choice for this one? All right, crickets. Somebody speak up.
I think in regards to just going back to, is the patient capable of taking a pill every day within that window of time? That eliminates that completely. And I mean, that's probably my biggest takeaway.
Yeah, and I say it mostly because I worked in an adolescent health center, so I have lots of experience. None of these options are necessarily wrong. It's going to depend on what else the patient has to say. I like Depo because it's every 12 weeks. Most of the time they can remember every 12 weeks, and I usually tell them to make an appointment at 10 weeks because that way if they forget, I still have room to work with them. You can give Depo-Provera early, you just can't give it past 13 weeks without increasing the risk of pregnancy. So you have like a 3-week window to track them down if you need to. It's something you can do in the office oftentimes. And so if parental consent is an issue, not consent, but if parental knowledge or awareness is an issue, they can come in for an appointment and get it done, and the parent doesn't have to know or go through their insurance or whatever. There's alternatives that way. The other thing is she wants her period to go away, usually after the first 2 injections. So by the time that's been 6 months, their periods go away and can stay away for 9 to 12 months, sometimes even a little bit longer. And it's really good for dysmenorrhea. So those are the 4 reasons why I would pick that one. My experience with Nexplanon in adolescent girls is they usually only have it in a few months and they want to take it out. So I think I might be a little bit biased there. I think on paper it's a very good option, but in reality, a 16-year-old, I don't know, always has the maturity for it. IUD is definitely a good option too, and oral contraceptive if they're responsible. All right, so did that discussion help on approaching a 16-year-old?
Yes.
Yes.
All right, does the thought process make sense to all of you?
Yes.
Okay.
Yes.
All right.
Something that occurred to me, and maybe it's too obvious to state, but because she's 16, I guess it would probably bear mentioning or educating that none of those options are going to protect her from a sexually transmitted disease. So
Yep.
she still needs to think about that.
Yep. And that's true of women of all ages, because especially married women, they don't think that they need to protect themselves. But just because you're not cheating doesn't mean that your partner isn't. And so I hate to say that. That's something I still educate everybody on, no matter what, that does not protect them. And if they have any concerns or doubts, they should be using condoms as well. Does that make sense? I counseled way too many
Yes.
women that were on the receiving end of unplanned marital affair and getting tested and or treated for STDs.
Yeah.
All right. So, okay. So this is a similar case, but a few other variables. A 16-year-old female presents with a desire for birth control, never been on birth control before. She has regular periods. They're painful. She would like them to go away. She admits to smoking a few cigarettes a day. So, and she's very responsible, does not want children ever. Now, what options do you have to consider? So what are your key things there to think about?
Can I just ask something in regards? I don't
Yep.
think we really mentioned it in the last one, but like assessing what type of pain the patient is having. You know, like is she having headaches or is she having like cramping when she has her period? I think kind of getting down to the root of where the pain is.
Yeah, and that doesn't
I
hurt.
don't know if we discussed that.
Well, dysmenorrhea is just is a diagnosis for period pain. So that's kind of inclusive in that. But definitely, if she came in as a new patient and you would explore what does she mean by painful periods. And if it's truly dysmenorrhea, then yeah, then what we're doing, we're going to assume that it's dysmenorrhea. But if you're not sure, yeah, you need to investigate that further before you start something, especially if they've been sexually active. Does that make sense?
Yes.
Okay. All right. So now what factors in this scenario do you need to consider?
The smoking.
The smoking. Yep. What else?
I mean, I don't know. She says she never wants children ever, but I mean, she's only 16, so I still wouldn't want to do anything that's too permanent.
Right, right. But we could consider even longer acting IUD than the 5-year, right? Because you can always take it out early. So that would be a reason. Yep. She may want children at some point. So we definitely wouldn't have her go through a tubal ligation, but we could definitely put her on something that is much longer acting. All right. What other clues are in there?
She's very responsible.
Yep. Yep. So what does that tell you?
That if she, I know you said the IUD is much longer lasting, but if that's something she didn't want, that you could probably trust her to take a pill every day.
Absolutely. Absolutely. She might be one of those that is like my first example that had the app, that had the period diary, that is going to do everything right, and that's okay. Now, if she's smoking, then what type of hormone do you need to consider?
Well, you don't want estrogen.
Right. So you've got to stick to the progestin only one. So what are your options there? Or non-hormonal contraception?
Like the IUD, like Mirena, is that hormonal?
Yes, but they're progestin, and then you have the copper one that is non-hormonal.
Is it the mini pill? That's
The mini pill. Mm-hmm. Which one did we use in the last case? Depo-Provera. That's medroxyprogesterone. So that one. So yeah, so you want to stick to the progesterone only class because she is a smoker. Now, let's say she is only having sex once every 3 months and she's very responsible. What would you recommend?
Condoms.
Condoms. That might be enough if she's that responsible. And remember, you have to think about frequency of sex, and we didn't talk about that in the last one, but that's a consideration also. Now, if she is in a relationship where they're having sex at least once or twice a week, that might change your options or what your considerations are. If she were concerned about weight gain, what would you do? It's quiet again.
Maybe lean towards the IUD or the barrier method.
Yes, yeah, you want the least amount of hormone possible. Now, Depo-Provera, I think the book tells you like the average weight gain is like 3 to 5 pounds or something like that. I think that that's probably true in studies, but what happens, and I see that saw this quite a bit, is oftentimes these girls are becoming sexually active about the same time that they're going through major body changes as well. And I've seen weight gain of 10, 15, 20 pounds that the girls will blame on the Depo-Provera. But I also think it's the same time as they're maturing and developing. And so it seems like they've gained a lot of weight because of the Depo, but in reality, it's because of the hormone changes in their bodies. Or if they're on medications for bipolar or mood disorders, a lot of those cause weight gain, and then combine that with Depo-Provera, and they can gain a lot of weight. So that's a consideration as well as something that's less likely to have that kind of a hormonal influence. All right, questions on that case. It was similar to the first one, but you can see how a few different variables kind of changed the way you think. Questions? And I did record this, and so in the Teams chat, you should be able to access the recording to review again if you'd like. All right, so this is another 16-year-old female, presents to you with a desire for birth control, never been on birth control. She has regular periods, no concerns except for acne. She does not smoke or drink alcohol. She's not sexually active yet, but may be soon. What are your considerations? So one thing I want you to think about is, I think there was a chart in your book, if I remember it. What are good options for acne?
I don't really know. I was just gonna say, like the combination of estrogen and progesterone.
Mm-hmm. There's some, and I thought there was a chart in your book, but maybe I'm hallucinating. I'm looking, sorry. I thought there was a chart that told you which ones were good for like acne, but I might have dreamed that. All right. Yeah, I'm not finding it. Okay, so yeah, so you want to look at, there's a couple of different progestin portions, I think, and maybe it was in my slides from a previous one that, sorry, looking again, that are you more likely used for acne than others. So I would just know that that's an indication, and some are better than others. And I would review that when you are trying to pick your type. Does that make sense? I'm going to ask that a lot. But you definitely want something that addresses the hormonal piece. And usually oral contraceptions are the best way. Okay. Now, why not? We haven't talked about the patch for any of these 16-year-olds. What would be some considerations for the patch, the transdermal patch? What are the pros of a patch?
Well, it's also easily discontinued if there's a reaction.
Yep, very, very true. Easy to discontinue if there's a reaction. What else?
You only have to apply it once a week.
Yep. Any other pros? Timing is not so important, kind of like with versus the daily dosing. You can be off a little bit on your timing. The cons to the patch, and I was a believer in the patch when it first came out. I mean, how easy. You don't have to shots, you have no pain. You don't have to go through a procedure. You just put this patch on and you take it off and change it. Well, what we found was there's a slight increased risk of blood clots with the patch because the delivery system can give them more hormone than expected, or more, it's not quite as even. And so initially there was increased risk of clots. Not much, but you definitely would want to avoid it in somebody that has a family history of clots, and if they're smoking, just like other things for that reason. And if you're unsure of the clotting history, that's one that I would stay away from. Like, let's say they were adopted or something. Okay, now let's move to a 35-year-old woman. She's a G3P3 single mom who does not plan on having any additional children. She has a BMI of 30. She does not smoke or drink, no CV risk factors. She is not sexually active, but beginning a new relationship. All right, so what are your key things here that you need to consider?
Her BMI and her age.
BMI and age, absolutely. So what do we know about age? Or what do we need to think about related to age?
Well, don't the risks from oral contraceptives increase after 35?
Yes, yes. So that's a consideration. Doesn't mean they can't be on it, any kind of birth control, but definitely got to think about that estrogen component. All right. What else about age? She says she doesn't want to have children, and the older you are, the less likely you want something short acting because you have already had your children. So right away when I see that age, I want to know, is she planning on more children? Maybe she is with her new relationship or not. So something more long-term might be viable. If she truly doesn't want any more children, what do you think would be a good option for her?
Well, if she's really, really sure, then tubal ligation is an option.
Yep, absolutely. What else?
IUDs.
Yeah, I would say probably an IUD, and non-hormonal would be best because of her age. But the other ones aren't necessarily contraindicated with this history, but definitely the older you get, the more that needs to be a consideration. And that way, in her new relationship, if she thought she might want to have a child, which I would like be crazy to think that, but women do, good for them. Then she could easily take that out and not have any problems. What about, we haven't really talked much about, let's say she was 25. We haven't talked about the vaginal ring as an option, and that certainly can be an option for any of our previous cases. What are the pros of a vaginal ring? No guesses?
I don't know a lot about it, but it seems like it would probably be fairly easy to discontinue. If there was
Absolutely. Absolutely. It's easy to insert. It stays in. If you're comfortable with your body, it's a great option. And that might be something that this woman might want to use if she were a little bit younger. And even at this age, it's not necessarily contraindication, but definitely increased risks. But I had a lot of women that used those and were very confident in them. And you don't feel it, you don't know it's there. And that might be a good option for a teenager as well, because it is so easy to use and it's not a shot. It's very reversible very quickly. They just have to be comfortable with their body. So there has to be a little bit of maturity level there. Okay, good. All right, so that's all the case stuff that I have for you. I can certainly make up some more in my head. After talking, what other questions do you have? Nothing? Was this helpful at all?
Yeah, I thought this was really helpful.
Okay. So like I said on that one slide, where to begin, I think you have to just keep going through that in your mind. You need to understand, first you need to know their history and review that thoroughly. And those absolute contraindications that are self or family history are important. You need to identify their risk factors through that same method. But also, what are their goals and frequency of sex? I think those are the two things that we often don't consider in our equation. But it does matter. If they're not having sex very often, then you might not need one of those things that are much more difficult to adhere to. But if they're harebrained or spacey, you might need something that they don't even have to think about. So it helps when you know your patients and you take a good history to narrow down their different options. Smoking, age, and history of the female cancers, I think, are the biggest deciding factors in addition to what we mentioned, because that will affect which hormone or non-hormone route that you need to take. But for the most part, there are several right options that you can individualize to your patient based on what those goals are. But you don't know if you don't ask, and one size does not fit all. Birth control failure is usually because of the incorrect birth control being prescribed to them, one that doesn't fit their lifestyle. Rarely is birth control failure occur when somebody's taking it as prescribed and when it's working for them. All right, any other thoughts? All right, well, if you have nothing else, I have nothing else, you can feel free to email me. I just wanted to make sure that I walked you through those cases and helped you to solidify that thought process so that when you approach a patient with birth control questions or prescribing, you at least have a framework to begin with. But also, maybe you're not going to be the one prescribing it. Maybe they come to you at the hospital. You need to understand if it's appropriate to keep them on that birth control, given whatever condition that they come in with, especially if it's a clotting disorder or a thrombotic event of some sort. That needs to be a consideration. And as we talked about, if you're in the OR, is that a consideration or should it be? All right. Feel free to email. Otherwise, the recording, like I said, is available in the chat. If you have trouble accessing it, let me know, but you should be able to open up Teams, click on the left menu on the chat, and it should pop right in there for you. And let me know what you think, and I'll be available as always. Have a good rest of the day. Enjoy this beautiful weather otherwise.
Thank you. Appreciate
Thank you, you too.
Oh, you're very welcome. Next time I want to see smiling faces. Bye.